As the nation's maternal mortality and morbidity rates have continued to rise over the last several years, perinatal quality collaboratives, or PQCs, have been working tirelessly to tackle this critical public health issue by improving the quality of care that birthing people and newborns receive. In 2017, Centers for Disease Control and Prevention awarded the National Institute for Children's Health Quality to serve as the coordinating center for the National Network of Perinatal Quality Collaboratives. NICHQ provides PQCs with resources, technical assistance, and training to enhance their overall capacity.
As the NNPQC, NICHQ provides training, technical assistance, and opportunities for mentoring to all PQCs. And for the last 5 years, we have supported their development and enhanced their ability to make measurable improvements around maternal and infant health care and health outcomes within their respective states.
PQCs improve gaps in healthcare by working with clinical teams, experts, and patients and families to spread best practices, reduce variation, and optimize resources.
So the most important thing about PQCs is that we're able to evaluate every layer of a healthcare encounter, of every layer that a patient connects to, sees, visits, everything. And we look at every single opportunity that we are able to improve the quality of care that we give patients, all in the overlying goal of decreasing infant and maternal morbidity and mortality in the United States.
As the coordinating center for the NNPQC, NICHQ enhances the collaboration and communication of PQCs across the nation, provides technical assistance, and advises state PQCs that are in the early stages of developing their collaboratives.
You cannot sit in a bubble in your own state and be as effective or learn as much or move as quickly forward if you're not learning and sharing and gaining perspectives from other states. I think the ability to have a network of perinatal quality collaboratives is vitally important, and the ability to learn and share from other PQCs is what keeps us vital.
From 2017 through 2022, NICHQ supported all PQCs nationally, including targeted technical assistance for 13 CDC-funded PQCs by increasing connection and communication among PQCs, their partners, and community members, expanding quality improvement knowledge among PQCs, and increasing the capacity of PQCs in early development and expanding and sustaining more fully functioning PQCs.
We offer facilitated and structured opportunities to help PQCs share their successful best practices, but also their challenges. And one of the ways we do this is through our bi-monthly webinars, which focus on topics that are important to PQCs, such as breastfeeding, maternal sepsis, racial equity, maternal mental health, and emergency preparedness. We also coordinate activities to support PQCs as they are working to address public health issues that are significantly impacting families and the health of families, like opioid use and neonatal abstinence syndrome, but also issues related to COVID-19 like vaccine equity and vaccine hesitancy.
NNPQC has been kind of the backbone to making sure that PQCs have resources and have access to experts and have access to knowledge and keeping them current with what is actually happening in the birth world.
PQCs across the nation, with the support of the NNPQC, have made strides in improving health outcomes in a variety of topic areas.
So the Louisiana Perinatal Quality Collaborative launched in August of 2018, and we started with the Reducing Maternal Morbidity Initiative, an initiative to reduce severe maternal morbidity from hemorrhage and hypertension by 20%, as well as to decrease the Black-white disparity gap. During that time period, we found a reduction in severe maternal morbidity from hemorrhage by 35%, by 49% for Black women, and a reduction in severe maternal morbidity related to hypertension by 12%.
One of our most significant achievements is the Colorado Hospital Substance Exposed Newborn Project, and that's a focus on neonatal abstinence syndrome. And we've implemented the Eat, Sleep, Console method. We saw a significant decrease in length of stay for newborns. That went from approximately 2 weeks
down to 6 days in all participating hospitals over the course of a 2-year period. Additionally, we saw the need for medication care to be declined significantly from about 70% in the beginning of the project to 0% over 2 years in those same hospitals.
The focus of our funding from the CDC was to expand participation of hospitals in the state of Florida. PQC has been around since 2010, but we've really struggled over time to get hospitals to engage in participation in initiatives. We went from participation of a little less than half of the hospitals in the state to over 75%.
We have been able to demonstrate impact with our participating rural facilities on both the maternal hemorrhage and severe hypertension initiatives. Rural hospitals met their 20% severe maternal morbidity reduction goal for severe hypertension by the end of the 4 most recent quarters, demonstrating a 51.3% improvement among transfusion cases and a 55.3% improvement among those non-transfusion cases. And at the 2021 annual meeting last fall, 16 rural facilities received our GAP-QC Rural Hospitals Maternal Outcomes Achievement Award to really celebrate that collective impact and facility-specific wins of our rural facilities.
In 2021, CDC recognized racism as a serious threat to public health. PQCs are uniquely positioned throughout the United States to advance health equity in maternal and infant health and promote respectful, equitable care through data-driven, continuous quality improvement practices.
When we launched, the equity landscape was very different than we have today. As a matter of fact, during one of our learning sessions, when we were just educating on equity, implicit bias, just giving out the terms, we had 2 hospital facilities walk out because they felt offended by the conversation. They later rejoined the collaborative and we were able to move forward, but it really was a fork in the road for us as a collaborative. We had the choice of backing down on equity, or we had the choice to step forward, and we decided to step forward. And though it has been difficult and it definitely was an uphill battle, I am proud to say that now here we are in 2022, and I'm very proud of the fact that we worked on equity when it wasn't popular, and we integrated it into everything that we did then and we do now.
Some of the most important work has been around our stigma and bias trainings, because it really is like what affects the families the most. Any issue that comes up that we're hearing from patients and families always ends up coming back to stigma and bias as the root issue.
We've been working quite closely with California and New York, Massachusetts. Also I've talked to Louisiana and Florida about the birth equity work that they're doing. And we've actually been meeting monthly and having a small group so that we can have an ongoing discussion about what's working, what resources are you using, what can we learn from each other.
I'm really proud to see so many PQCs start to focus on equity and start to enlarge their tents and thinking about who's not at the table, who do we need to hear from.
Perinatal quality collaboratives allow hospital teams to play at the top of their game, to really make their team as efficient and safe and effective as possible, and that trickles down really significantly to help improve patient outcomes.
I think some of our most enthusiastic collaborators are former patients and family members, and they continue to help us shape and guide our initiatives.
We heard from a lot of providers that birthing people would come back to the hospital once discharged having postpartum preeclampsia with symptoms such as headache, stomach ache, nausea, things that they may otherwise have just thought were part of the birthing process. Because they were educated as a part of this project, they came back to the hospital, were treated appropriately and quickly, and we heard from providers that they considered those to be lives saved.
One story that touched me personally was an individual who struggled with suicidal ideation during her pregnancy, and she had a very challenging pregnancy and was not able to receive care prenatally because of a long wait list to access behavioral health resources. She volunteers with us now, and she's like, I will walk to any doctor's office, any hospital, I will pass out pamphlets, I will shout from a rooftop. Like, I never want anyone to have to feel alone and like they can't get the help they need. And it's
why we do our work.
The work and dedication of PQCs across the nation makes shared learning and growth a reality.
One of the things that has been really incredible to me are the countless examples of how PQCs have learned from one another and supported each other. It also shows how important these state networks are in breaking down silos as they work within their individual states. We are so excited to have the opportunity to continue supporting PQCs as they collaborate with not only us, but most importantly with patients and families and communities and birthing facilities to ensure care is respectful and equitable.
What we're realizing is any PQC that operates in the clouds and never touches the ground cannot really fully impact the change that's happening in the community. So I'm proud that we are finally touching the ground.
Perinatal quality collaboratives are instrumental in changing the lives of mothers. By making sure we are working with hospitals to improve readiness and recognition, that means every patient, every time, gets the best care.